Thumbs up. Should I go? Okay. Afternoon, everyone. Hopefully you'll be getting your dose of sunshine, getting a screening for skin cancer after that dose of sunshine from the Mount Sinai booth out there, and got some food. Got a great chat for you this afternoon about do we get what we pay for in American healthcare. I'm Atul Grover from the Association of American Medical Colleges. We are one of the underwriters of this event and very happy to be so. And my main goal here today is to get you to turn your cell phones onto silent, please. Keep them on and keep tweeting, particularly if you have disparaging remarks about any of my three colleagues up here. But keep them on silent, please. And I certainly have no other role in that except to say you've got a terrific panel. I wanted to find the joke that began with an economist, a surgeon/senator, and a psychiatrist walk into a bar, but I figured you'll say the funny stuff and talk a little bit about what about all the things that we need to pay for that certainly Dr. Davis and Dr. Frist are familiar with: research, education, training, care for really sick people. How does that all fit in? Thank you.
Thank you. So, we're recovering a little bit from the soccer match up here, and Uwe in particular, I think, is struggling. He was a bit conflicted. And is there a psychotherapist in the audience that could work with Uwe? Do you have any? You doing okay?
I'm okay.
Yeah.
But I don't know if you noticed what a grim face the German coach had.
Yeah, even though he won.
Explain it.
He just won. Well, it's because when you ask a German, how are you? He will answer, it could be better. And it's a classic.
Sort of like the healthcare system, I suppose. Well, listen, thank you so much for joining us today, and we're going to talk today about the cost of healthcare and the question: will we ever get what we pay for? As you all know, the U.S. spends far more on healthcare than any other developed nation by a long shot, and while the rate of increase in spending seems to have declined over the last few years, we still spend $2.8 trillion a year. And we have issues with safety, we have issues with quality, we have issues with care fragmentation. Americans do not fare well on measures of health internationally when you compare health outcomes. And so there's a broad perception that we just do not get what we pay for. So today we're going to explore healthcare spending and costs, the impact of recent legislation and reform initiatives, and we will address the question of whether we will ever get what we paid for, and if so, how. So as you can see, we have a very illustrious panel here today. I'm going to introduce each of them. I'm only going to give sort of the Reader's Digest version of their bios, or we'd be here all day long. So I'm going to, in alphabetical order, I'm starting here with Dr. Ken Davis. Ken is the President and Chief Executive Officer of the Mount Sinai Health System. He also served as the Dean of the Icahn School of Medicine at Mount Sinai, was chair of Mount Sinai's Department of Psychiatry for 15 years, was president of the American College of Neuropsychopharmacology, and has had a long and distinguished career in neuropsychiatric research, for which he's received extensive national recognition. Bill Frist, as I'm sure everybody knows, Senator, nationally recognized heart and lung transplant surgeon, and former U.S. Senate Majority Leader. Senator Frist is chairman of the Executive Council of Cressy & Company and co-chair of the Health Project at the Bipartisan Policy Center. As Majority Leader of the Senate, his leadership was instrumental in passage of the 2003 Medicare Prescription Drug Improvement and Modernization Act and PEPFAR, the President's Emergency Plan for AIDS Relief. Dr. Uwe Reinhardt is the James Madison Professor of Economy at Princeton University. He is a leading health policy expert who has advised various state and international bodies, including the World Bank, the Physicians Payment Review Commission, the Department of Health and Human Services. He's a member of the Institute of Medicine and has served on the board of Duke University and numerous other health systems. He's widely regarded as the world's funniest economist. He has a stand-up act in LA. You really shouldn't miss it. So I'd like to, I'm going to start the conversation by posing a few questions to these gentlemen. But we're going to do that for about 30 minutes, and then we're really going to go to the audience to handle your questions. So start jotting them down, and we'll try to get in as many as possible. Then I'll come back for about 5 minutes of wrap-up. So I'm going to start with Uwe. You know, as I alluded to in the intro, there's been a great deal written and said about the fact that healthcare spending appears to have slowed down, or the rate of increase appears to have slowed down over the last few years in this debate as to, is it the recession, is it structural factors, and where do you come out on this, and where do you lay the most, if it's structural, what's really driving that, and is this going to keep going? Is it going to slow down, or what are we looking forward to here?
Well, thank you. First of all, I do want to observe, I seem to be the only doctor here with a PhD, which our daughter, who has an MD, says, "Daddy, PhD is Greek for a doctor who cannot help you." So I don't know why I understand it. But I will now break the, must be 18th Amendment of the US Constitution, which means you must never question American exceptionalism. And just in today's JAMA is a paper that shows that the spending, the decline in the growth of spending in Europe matches ours pretty much exactly. In fact, when you take the difference between growth in health spending and growth in GDP, we call that excess spending, that's the name for it, of the US and Europe, the two curves almost coincide. So obviously, in my view, that must mean the recession had a lot to do with it, because the Europeans didn't raise deductibles, didn't do bundled payments, didn't do any of the things that we did, and yet their decline is very similar to ours. I think the recession had a lot to do with it, because there is a fairly tight correlation between GDP growth and health spending growth, although health spending lags a year, year and a half behind that. But we did do other things in the US. I think the great sleeping giant, the employers, are finally waking up. Before the year 2000, an employer, they paid every check from healthcare that came their way. Often it meant they actually paid the invoice number. The first number they saw, bang, they cut a check. I think those days are over now. They bestir themselves in various ways. A, by raising cost sharings on patients with deductibles, co-insurance, or not covering things they used to cover. But I think they also bargain more harshly with the insurance industry. So that is one piece of it. Peter Orszag yesterday pointed out that Medicare spending growth had abated many years ago. And he believes this has nothing to do with the recession. I would disagree with him in the following way. If the AHA, the American Hospital Association, goes to Congress and pleads for higher updates, higher price increases, in a recession, Congress has a much better position to say, love to do it for you, Dick, but we have unemployment insurance benefits, we have more Medicaid people, our budget is tight, can't give it to you. I think it's easier to do that in a recession, to tell the AHA to lie low, and the physicians, than when things are booming. So there is a recession connect. Yep. But I think if economic growth picks up again in the US, there are two things you have to keep in mind. The first one is economists measure everything by averages, average growth of GDP. This is really not very smart. In fact, it is quite tragic. In the 1930s, the entire Harvard economics department drowned. And what happened, they had a picnic, and they walked through a lake that they knew on average was 3 feet deep. This is classic economics. If you take Piketty's work and say, take the top 1% of earners out of our society and do the same with France, we actually, for the 99% average GDP, grew less rapidly than France, and in the future will grow less rapidly than GDP that you see in the headlines. So I don't think the typical average American is out of this recession. We're facing slow growth, so we will not have what we had before, which was GDP, health spending grew 2 percentage points faster than GDP. You'd be lucky to get a 0.5 percentage point differential.
Can I ask a quick question? First of all, Uwe was my economics professor in accounting and in macro finances 30 years ago. So our relationship is a special relationship. So first of all, that was brilliant, all that, because it really was. Structural of all this flattening, Is it 50% structural and 50% recession, or give me a number?
Oh, I would never say 50.
Yes.
50.
Oh, 50 what?
No. I would say 38%
What?
versus 62.
What? Which is which?
That doesn't matter so much as to say you never give even numbers. That means you're thoughtless. You have to
Add a 2 to it. The surgeons, we think simple. We just round everything up. The economists, you know.
But isn't that you estimate coronary artery closure? It's sort of, you kind of feel it, right?
Anyway,
Sort of,
so
exactly.
it's, but roughly half and half, right? Don't you think?
I would say probably 60% was the recession.
And
the
40%
other
structural reform.
Well, again, not
So let me ask you a
38
question here.
was a good number.
So Bill, Affordable Care Act, we've 60% is this maybe the recession, the slowdown. Now we're insuring this year, 8 million new folks, and next year more, and so forth and so on. And and that's a good thing. But of course, when you do that, you decrease barriers to access, and more people will have access. Are we going to see a cost acceleration here? And does the ACA have in it, built into it, sufficient levers to pull to constrain cost growth as needed?
No.
Okay.
No,
Next question.
No, I think. How long did you take? The economists, that old joke about the economists know everything about pricing, but nothing about value.
Right.
Right. Okay. So the Affordable Care Act, and most of you have heard, I'm Republican and all that, and but at the center of gravity of it it's a good, not a good bill, but a good effort, a good initiative that I'm glad happened. And the thing is, it's an access bill, and I know everybody will come out and say, no, it does all this other stuff. But at the end of the day, it is an access bill. It is not a cost or even a spending bill. It's just not. Mm-hmm. And the quality, there's quality in there, and there's accountable care organization. We'll get to that and all in there. But if you step back, the purpose of it is insurance reform. 16 million people in Medicaid, 16 million people of the uninsured in exchanges. That was the way it was written. That's the way it was intended. The cost and the spending issues, and we'll talk about some of the initiatives because the demonstration projects are good. They take a long time to see the results from. They probably incrementally accelerated the reform that was going on in the private sector anyway, but it took it up a notch. The curves are probably still at the same slope. But you look at accountable care organizations, and we'll really get to the expert on that, is there are 150 of them out there under the federal legislation. It's integrated health care, continuity over time. You get everybody in a room and you deliver care instead of the fragmented fee-for-service. That's kind of what an accountable care organization is. So the federal version of that, there are 137, if you add the Pioneer and the other together, to date. And of those, only about 40% showed any savings at all in a year. A year is not fair, but that's the data so far. And of those, only probably 16 or 17 of the initial ones were able to share in the cost savings model. Now, he'll tell me and everybody that's not good enough data, but that's the data that's out there. The real excitement about it is the incremental step function of sort of saying integrated health care with continuity of care over whether it's bundling or a period of illness is a good thing. And the Affordable Care Act, it talks about it, does a little bundling and all of which is good stuff. But in terms of being a bill, its purpose was access and was not cost and not cost savings. In fact, you can end up spending about $2.6 trillion over the next 10 years more than you would otherwise. $2.6 trillion.
So for all the increase, Ken, I want to come to you. Ken, you run a healthcare system, a big one, in New York City. And you have a population that is underserved, in general, underinsured. I would dare to say even with the ACA probably. And you're also an academic medical center, costs of research, teaching, so forth and so on. What does this all mean for you? I mean, because again, back to the average thing, not all medical centers and systems are the same. You occupy unique strata in American medicine as an academic health center. And I just want to get your perspective on what the future looks like for you.
Well, lots to say about this. And I want to start by commenting on what my colleagues have just talked about. Although, like them, I conceived the ACA as largely a bill about access. I'm surprised at what are the trends that are happening in healthcare now, some stimulated by that bill, some stimulated by other factors. that really are changing the utilization of hospitals. I mean, I see it across our 7 hospitals. I see that the number of inpatient admissions is significantly down. I see ambulatory care is significantly up. So utilization of the most expensive services is changing. Now, whether that's in fact because of the readmission penalties, or whether that's because there's more managed care from Medicaid, or that's because ACO-like organizations are creeping into some of the insurance products, or we're all getting ready for what we see as the inevitable change as we move away from fee-for-service to taking risk in population, I think there are trends that are going to decrease cost over time. But what we've alluded to but haven't yet, I think, elaborated is that the demographics of the United States work against healthcare economics being more austere. It's clear that as my generation ages and we develop all the chronic diseases that we do and we prolong life as we are, that we're going to have a lot more expense. And we have to deal with the fact that this generational problem has to drive healthcare costs. And even if we're much more effective and much more efficient, that demographics is a tsunami.
Yep. Yep.
I think that's right, but I think we'd all agree that 20% of the healthcare dollar today is wasted. And I think that much of our, if we're looking for value, and we'll talk a little bit about what value means, but at the end of the day, we got an inefficient system that we can do a lot better on. I would argue that the Affordable Care Act, and that's not the purpose of this panel, didn't provide, and the purpose was not to provide the answers to that, but it was more the access issue.
So one of the
Actually, on this point, I happen to have the numbers.
you have a slide?
No,
Want
but
to hold that up?
He'll draw a graph.
Yeah, no, I know.
the Institute of Medicine had a publication about 2 years ago, Best Care at Lower Cost. And they had an estimate of
Right.
waste in 2009.
Yeah.
Unnecessary services, 210 billion. Inefficient delivery, 130 billion. Excess administration, 190 billion. And it goes on, the total is 765 billion, which is 31% of the 2.5 trillion. Now, you could argue about some of these items, but you made it 20% waste.
Yeah,
I would have made it 21, but again, but it's certainly a number north of 20%.
But let me speak to that for a second, because one of the little-known aspects of the ACA is something called administrative simplification, which is supposed to be around the corner. Now, what does that mean? Let me give you an example. At Mount Sinai, we have 250 different health plans that we deal with. Consider what that means, 250 different health plans. So everyone has different rules, everyone has different denials, different claims processing, different claims form, it goes on and on and on. It takes an army of billers to take care of that. And then there are the denials and the appeals, and it never stops. The question is, how much administrative overhead have we built into this awful, inefficient, dysfunctional system, and how much is it costing us? Other IOM reports estimate that to be about 10%. The ACA is supposed to address that. I'm still waiting for it to happen.
Yeah, go ahead.
So administrative simplification, he taught me and everybody, we're probably twice as bad as any country in the world in terms of percent, whether it's 10% or 6%, which is what you used to tell me, or 6.2% used to tell me. There's a lot that can be done, but it's a good example. The Affordable Care Act has an administration simplification, and there's 6 provisions in there. It takes effect here in about 2 weeks, so we don't really know. But it doesn't even attempt to address really, it'll go from 6.2 to 6.1%. But this whole idea of administrative simplicity. In the old days, when he was still in Germany and he first taught me, he would have said single payer system, right? Or I don't know if he would have said it really, but I used to say you'd say it. Single payer system or whatever. But now we've sort of gotten away from that. And the beauty of our system in many ways are all these plans that are out there. Maybe not 200, it should be 5. But the fact that we do have some choice and the fact that they're out there, and is that some of that administrative expense just part of the complexity, part of the expense that we pay to have a pluralistic system?
Yep.
Or is it
Let
part of the business model of the insurance companies?
Exactly. Well, that's good.
Yeah.
That's
Let
good.
me just shift gears for 1 second. I want to, because I think this is important. This has been in the press quite a bit recently. Gilead just came out with a new drug, Salvati, I think it's called. It cures hepatitis C, and it costs $84,000 for a 12-week course of therapy. Huge uproar about this. Now the question is, are we getting what we pay for here? And what if there are many more drugs like this? Will we, even if we are, can we afford it? And so how do we tackle this? How will we know if we are getting what we pay for, and how do we value it? And I'm going to start with you. You've spent a good time developing pharmaceutical products, so your perspective on that.
So my perspective on this may be very different from my friend the economist's perspective on this. I know you can make a business case and an economic argument for why they should charge $82,000 or whatever they charge.
82.5.
Right, 82.5. Yeah. But I'm also a healthcare populist and an academic elitist. And from those perspectives, my thoughts are these. Imagine if the polio vaccine had been priced at the savings downstream for healthcare. Imagine if the first drugs that treated tuberculosis charged what they thought was the savings as we close tuberculosis sanatoria. I don't think that this is the appropriate business model. Now, I'm far from anyone to say I'd like price controls, I'd like some panel to figure out what this is, but I think in a democracy like ours, in a capitalist system like ours, I think there has to be responsibility by the individual and the corporation. And that responsibility says, I'll set this at a fair price for return on investment, not an obscene price.
So let me ask, I asked Uwe this question this morning. I didn't understand the answer, but maybe when he says it to you, you'll understand it. So Uwe, how do we get at, really, how we'll know whether we're getting what we pay for? How do you answer the question unless you know how to measure it or assess it, or how will a bell go off? What will tell us that we're getting what we pay for?
Well, there are several approaches, as you can imagine. 2 economists, 3 opinions, and here you got one and I give you 2. I don't know, is Troyan Brennan in the crowd? He has a paper coming out. He works for CVS. He's the medical executive vice president for medical affairs. And he has a paper coming out soon on this issue. One approach is to say, what are we spending now? Take that as a baseline. And then if we use Salvati, would that be cheaper? And I think you will hear and find on that basis, it's actually justified, even at $1,000. Although, again, by now, I would have priced it $8.99, would have been much less media brouhaha, 1,000 journalists latch onto. But it's probably cost effective. But Ken's question is also a good way to think about it, because there you really ask, how much should you ask taxpayers to pay taxes to buy an extra life year for someone they don't even know? And that's a quite different question. And we don't have an answer for this, because you could only discuss that if Sarah Palin and Betsy McCoy were having government-financed sabbaticals on St. Helena. Then you could probably have a discussion on this without being called a Nazi, because that's what happened here. They accused our president of being a Nazi, so to speak. You can't have a discussion like that. But that is what Ken is really talking about. Should it, like, for example, in terms of entrepreneurship, if they had priced it at $500 a pill, just hypothetically, they bought the company that makes it for $11 billion, and I think at 500, their revenue would be something in the neighborhood of $125 billion. And in it must be enough profit for an entrepreneur to be incented to invent. And we need some discussion on that, and I'm glad you raise it. But I can also see the economist view to say, look at the baseline, look at what this will cost. This will probably cost less. Therefore, it's a better deal than doing what we now do. And that's how they're priced.
Bill, I want to just come, because I know you've been a strong advocate for the consumer being the arbiter of value. And how does the consumer voice work into this, and how do we empower the consumer in the role of moderating price in the healthcare system?
I'm optimistic about the future in healthcare, and even healthcare prices and the access issue. And I think it's going to, in large part, be driven by having 100 million people shopping versus 535 members of the Congress setting prices of what a doctor is reimbursed on a visit, or telling you for Medicaid, I'm going to give you 60 cents on the cost of your dollar, and then dumping another 16 million people into a program that he's getting, what, 80 cents on the
80
cost
cents, yeah.
dollar. Yeah, it doesn't make sense. And so we can, and again, the Affordable Care Act didn't even attempt to, that wasn't the purpose of it, so I'm kind of defending it now. The purpose of it wasn't address sort of the healthcare system. It didn't change really anything. The real power, and we're seeing it with much higher deductibles, this trend over the last 5 years of going from $300 deductibles to $2,000, to health savings accounts, to the empowerment of individuals. The individual today in the doctor-patient relationship, which is where I operate mainly, to have a consumer, a patient come in and for the first time say, is your colonoscopy, what is the charge? And 3 years ago I couldn't answer that. Or what is the charge? What is the cost? Two different issues, but what is it? But then if the next question is, why in San Francisco is it $800 2 blocks from here, and over at the Academic Health Center 9 times that, it's $7,000. The question from the consumer, you say everybody in this room doesn't have to be smart consumers, but if these two tables are smart consumers, that drives me, the provider, to change for everybody else. And it has me, all of a sudden, the doctor or you, who runs the large system, to say it really doesn't make sense. So when you empower the consumer with the information, which very much the last 2 days have been about, this flow of data and big data, and what are we going to do with it, and the devices that we have, and what we can tell is going on in our own bodies. I got my EKG in my pocket now, and I'm wearing my steps and my sleep. You get empowered with the way where with a couple of clicks now, we're just getting to the point to look at the price transparency differential. We're probably 2 steps behind in quality, and we'll come back because quality is tough. Human biology makes quality tough. The fact in each cell in my body, I've just knocked off 100,000 cells. There's 3.2 billion bits of information in every cell that just I knocked off. That's human biology, so it's hard to put quality around that. But you put all that in, the empowerment of the consumer today with price and hopefully sort of transparency coming very quickly over the next 3 years, with the information, the knowledge-driven economy that we're in, and then you couple it with a financing system where you're making me responsible, where my decisions say I go for $800 or I go for $7,200, I'm hugely hopeful. A long way from where I sit as Majority Leader of the United States Senate trying to write legislation that's dirty, that's messy, that's never going to accomplish. It's too static to be able to stay as flexible, as dynamic as we need to be.
But this was a very subtle point you made. I hope you learned it at Princeton, not at Harvard. Which was, in a market, if a provider really hurts when they lose 10% of the clients, you don't need more than 10% of savvy buyers in the market to make that market work.
Right,
in other words, not everyone has to have a computer and all this stuff. As long as 10, 15% are alert and can hurt a provider who overprices, you will have the market.
And that's why when people came to me with the Medicare Modernization Act in 2003, they said seniors are not smart enough to be able to shop for their prescription drug plans. People came to me and said, you can't pass this bill. And we passed the bill, it was the Medicare prescription drug bill, that put plans out there that compete one to the other. And sure enough, because whether it's a nursing home or assisted living, you had your 10% sitting there, and all of a sudden everybody became smart consumers.
Yeah, you touched on something I want to ask Ken about. In healthcare, typically, whenever we introduce a new technology, it seems to cost more money than save. It's sort of different than most other industries. But one gets the sense we're on the precipice of something very different these days. With the mobile revolution, the digital revolution, the ability to be connected 24/7, in theory, to your provider, and upload all sorts of sensor data and journals and diaries of what's going on. It seems like the whole definition of access and you're able to monitor patients is really changing in an era when chronic disease is really important to get our arms around. And Ken, I just, what's your, is that, am I sort of being Pollyanna-ish and over-optimistic about the potential of this, or do you think there's something really there?
No, I think there's something there. We talk a lot about personalized medicine, we talk a lot about genomics. I don't think that's going to have the influence that apps will and some of the things that we're going to be wearing that will monitor our health metrics. Let me give you some examples. We're sitting down with Google X. And Google X is going to be working with us around a whole bunch of monitors that they can put in patients, just from an armband, a wristband, and a contact lens. So we'll be able to monitor your oxygen saturation, your glucose levels, your EKG, your blood pressure, your pulse, on and on and on. The problem isn't that we can't monitor it. The problem is, imagine how much data that is. It's an overwhelming amount of data. So we've already been thinking about that, and for our genomics projects and our Epic electronic medical record across 7 hospitals, we have built a supercomputer. It's so big it has its own name. It's called Minerva. And what Minerva does is sits around and crunches data all day. So what we're looking toward now is developing the algorithms that will be able to identify the risk factors that are happening in all those metrics as you monitor them, and then send an alert to your iPhone or whatever cellular device that you have, or a push message that says, get in touch with Mount Sinai, and we'll have the number, and then we will facilitate their quickly getting care. Now, I think that's going to be the future. All the technology is there. The problems are all engineering to solve it. That can decrease cost, because as we move away from treating illness and more toward prevention, that's how to prevent. That's how to prevent those hypoglycemic episodes or those really bad diabetic problems before they occur, the EKG problems before they're really serious. Lots of good possibilities here.
But how do you get paid for all that?
That's a problem. You know, and it's particularly problematic as my colleagues demonize healthcare centers, because there's a reason why some hospitals have a $7,000 charge and others have a $900 charge, and it has nothing to do with these evil people like me who are sitting around thinking, they won't know, we can really get them. It's not that way at all. I mean, what happens is these are charges on a charge master that nobody pays. The only people who pay this are utterly uninsured people. And for those, at least in our hospital, there's a sliding scale that relates to your ability to pay. So this is a bogus argument at the end of the day. The question, though, that Uwe raises, and he raises appropriately, is what would happen if we had reference pricing? How would that begin to change the whole nature of the negotiations that we have with a United, with an Aetna, with an Oxford, with all the insurance companies that then create these funny charges that we have?
So I'm going to ask one last question, and then we're going to go to the audience. So Uwe, just to change gears a little bit again, so huge consolidation going on in American health systems as large systems buy up. You guys have acquired a number of hospitals, and really it's the drive to manage population health. I'm sure that you see coming down the pike that's driving this, because you're going to have to manage risk. But from an economist perspective, do you have a concern around the kind of consolidation that's going on and sort of local monopolies being created and having real dominant weight in the market that will eventually drive up price in that market?
Yeah, I mean, economists see both the virtue, the potential, economies of scale, integrated care, more value for the dollar. But on the other hand, also concentrated market power. So even if you had bundled payment, the bundle may cost you a bundle. And that's really the problem. So the Federal Trade Commission is very focused on that. Martin Gaynor, an economist, they're watching this extremely carefully. So economists with ACOs really have mixed feelings the way I deal with it. On even-numbered days, I think it's actually a good thing, et cetera. Odd-numbered days, I worry about the market power and pricing. And we've seen it. There's a lot of research that shows where you have highly consolidated hospitals and less consolidated insurers, prices are much higher.
Please, yeah.
This is a really, really important point. I think the reference-based pricing we ought to come back to.
Could you explain to people what that is?
But
Does everybody
yeah,
know what that
first of all, reference-based pricing is like a reverse deductible. Right now, if you have a deductible of $1,000, you pay up to $1,000. After that, you're scot-free, so you're not a very smart consumer. It doesn't matter because somebody out there in the space is paying for it. Reference-based pricing is a little bit different. And now that we can measure quality a little bit better, you can do it. And basically, it says that there are 4 centers in the area that you can go to, and you can choose and go to any one you want to based on your app and your information, and that's good. But if, say, a colonoscopy is going to cost more than $1,000, if you want to go to A and it's $1,000 or $800, here's your $1,000. If you want to go to B, because it's got some hotshot doctor over there and it's going to cost $1,200, You, the individual, is responsible for the $200, or if you want to go to a place, it's $400. And so that's what reference-based pricing is, like a reverse deductible. And I think all of us would agree it's used everywhere else in America and in the markets. It's rarely used in the healthcare sort of cost spending market world. And I don't know if we need to say a lot more about it, but reference-based price, you might just comment, and you as well, it's a big deal.
Yeah, I think Ken, go ahead.
Yeah,
Did you want to jump in earlier? Or is it?
Go ahead.
Go ahead.
I have
Uwe.
You probably heard Dina Bravato of Castlight. She was on the stage, in fact. And they facilitate reference-based pricing and applied it to hip replacement and knee replacements, where they basically gave the employees a price list. Here are these hospitals, and here are their prices. That's what you'll have to pay. We'll give you $30,000, and here are the hospitals that do this procedure. I think Cedars-Sinai was one of them, was actually in the mix. And they have to look at quality, but they do. They also have quality data. And so if you go to any of those, they'll do it for the 30 we gave you. If you go to one that charges $90,000, and there were some, you pay the whole difference out of pocket. They introduced that, and I think within 2 months, the prices of the high flyers collapsed closer to the reference price.
Yep.
So it's a very powerful tool to marry social solidarity up to the reference price and then play raw market. Now, I could imagine Ken would be frightened of this, but maybe not.
I'm a little frightened of that, but I'm frightened of a lot of other things. And one of the things I'm frightened about is your comment that on odd days you're not sure about whether this consolidation is good, or on even days you think it's good. Let me tell you why, at least for now, at least in New York, why this was good. Hospitals in New York are often social mission-driven hospitals. You don't have a lot of hospitals that aren't doing obstetrics, pediatrics, psychiatry. And in the system that we have, we do 18,000 deliveries a year, lose money on every one. We have 500 psychiatric beds, lose money on all of them. How do you take the macroeconomics of healthcare, in which the employer can't afford healthcare, the government, feds can't afford healthcare, the state can't afford healthcare. How do you develop a more efficient system? Everybody wants to take 20% out of the system. Where are we going to take the 20% out of the system? Well, one of the ways you do it is you don't have a pediatric ICU in 7 hospitals. That's what happens when we consolidate. Another way that you do it is you consolidate all the psychiatric beds in one place. Another way that you do it is that one of our hospitals, which was doing 20 kidney transplants, stops doing them so that the other hospital, which is doing 350 kidney transplants, does all of them. Now, the communities get upset when that happens. And sometimes politicians cave in. And they say, oh, we got to keep it open. How can we not have a pediatric unit? How can we not have a psychiatry unit? But if we're going to save money, we've got to start clinical integration. And then we have to have that corporate integration that works with that as well. Otherwise, these behemoths will be as efficient as they've ever been. And my fellow panelists in the next couple of years are going to continue to demonize the hospitals at the same time that they'll be worried, oh, the FTC better not let you guys consolidate.
I think you're, by the way, I think you're a great guy, no matter what everybody says about you.
love
So now it's time to go to the
love
audience.
hospitals.
It's time to go to the audience. And the first hand up is out in the corner back there.
Get these guys to give up.
Hello. This one's for Professor Uwe. I had a chance to ask Thomas Piketty last week,
There he is.
last month, what you just mentioned. What happens if you pull off the top 1%? What is he seeing and is trending in terms of, we'll say, economic prosperity for middle-class income or middle-class income earners? Can you take that a little further into adding on the quality of healthcare and how it's increased over the last 30 years in that time frame, and putting it in any kind of perspective on whether or not it's gotten better, it's cheaper for people overall in terms of what we're getting compared to 30 years ago, or as he walked away from me and didn't answer the question, but you answered today, is there no correlation?
And can I just ask all our panelists, let's keep our question, because I want to get as many in as we can. So, yep.
Well, actually, the interesting thing is, I think you can measure cost, which is always per unit of something, either cost per treatment or cost per unit of output. Take, for instance, heart care, coronary care. The cost per unit of output, say additional life years, actually has gone down substantially over the years. So for the money in heart care, Americans get more. But if you look at cost per treatment, that's gone up. This is very confusing, but you really have to think, do I measure cost by inputs or by output? If you do output, American healthcare in many areas has actually gotten cheaper because you're getting more. The problem is that for the average American family, if you look at Milliman Medical Index, it costs now $23,000 per year for a family of 4 for healthcare. The median income in America is $50,000 family income. Do the math and see how that works. How could those families with making less than 50 pay for a product that costs $22,000 without us in the upper income distribution subsidizing them with tax money? That's the big dilemma.
Yep. Next. Lady right there.
So what happens to the doctors? Do we still have doctors who want to go to school? Are they going to make money? I'm kind of, you're talking about all the data you're going to collect, and you can subsidize and make different things happen, but what happens to our young people? Are they going to go out there and say, is it even worth going to school anymore?
You need to answer it. I'll set you up because this is critical, and this is where the academic health center, and I think it is very important for this audience to don't go into the details about what it costs to train, not just a heart surgeon, but a primary care doctor. I was in Rwanda 5 days ago, and there's a woman there, 40 years of age, an orthopedic surgeon, a specialist out there, which she decided to dedicate 2 years of her life to serving people around the world, service-oriented. I pulled her aside, and she said, I asked her, how much do you have in loans? And at that age, 40 years of age, after working hard as even a specialist, but developing service, has $200,000 in debt today. Anyway, I would basically say the role of academic health centers in training is huge, and it's at risk.
At risk. We train 2,000 residents. We receive payments from the government, indirect and direct medical expenses that we get per resident. It astounds everyone to know that as much as we are paid, it still doesn't cover what are the real costs and the subsidies that we have in the medical center, the academic medical center, to keep it alive. But the question that you raise, I want to address in a slightly different way, which is the young person who's going into medicine today, who thinks they're going to be gazillionaires, making a big mistake. Yeah. They've got to go into medicine because they want to heal, they want to relieve suffering, or they're scientists and they want to find a way to develop the next generation of therapeutics or understand pathophysiology. But if we make the barriers so high because the expenses are so great and their indebtedness is so huge and we can't find a way to relieve that, we're going to have a hard time getting the best people to be in medicine.
We can't.
Let's go.
Go ahead.
Well, yeah, let's go to another. Anybody over here on this side, or is this all on this side? Yeah, back there, way back there. Wait for the mic. Hold on a second.
You've mentioned today alternative payments such as bundles and ACOs. How about just death to fee-for-service?
What executioner up
Question
there?
fee for service?
Yeah,
It's going to die.
Yeah, fee for service over the next 3 to 5 years will die. And there'll always be markets, and there'll be plastic surgery, and there'll be LASIK and all. But at the end of the day, the movement, and from theoretical people to policymakers to practitioners, people understand we're going to move from a volume-based, coming back to what Uwe said, from a volume base to a value base. So the discussion is about how you define value, which is what we're talking about, from a fee-for-service to a value-based reimbursement. And it gets you away from all the 10,000 codes, which I, as a legislator, would have to put my stamp of approval on, which are really 110,000 codes today. It gets away from a lot of that and allows, ultimately, as does bundling itself, for the decisions made, instead of at the macro level, at the micro level, where the people are doing the heart transplant, you have the social worker, the heart transplant surgeon, the pathologist, the perfusionist all together, and having the allocation of resources and a bundled payment there, instead of paying each one fee-for-service for every interaction. So, but it's pretty much accepted by everybody. We're moving from volume to value.
But I think it'll take longer than, it's very complicated in this sense. It's supposed to be evidence-based bundled payments. So you first of all have to have physicians agree what is the proper treatment for this condition, and does it have a beginning and an end, like a transplant? first we have to, that means making eagles fly in formation, never easy. Supposing they agree, then you have to price out the bundle and say, well, here are all these services, and we have to put a price on them. And then you add it all up, and you get the bundle. Now, somebody has to get the bundle and then pay all the others who participate in it. So you need an organization that can do that, and that's where the ACO comes in. Yep. Normally, I mean, the idea that all these doctors would meet in a Holiday Inn Saturday morning to divvy up the bundle, surgeons with their knives there, I don't think this would be a good thing. So you need an organization to do that.
I don't know. If I do a heart transplant and I have my team there, and I do it through the hospital itself, and so we make an agreement, but basically the hospital or the head of the team gets up $200,000, and then after that the decisions are made. So it can get complicated, but it can be very, very simple. And for joint replacement, for anything that is, as you said at the beginning, and episodic, we can do it. The hard thing is for the chronic disease, which is where the real problem, the real challenge, the real money, as we all know, we're moving to the chronic disease, that becomes much, as you said, harder to do.
But can I ask you a question? Supposing you had a coronary bypass,
Yeah.
right? That's sort of beginning and end. But depending on the comorbidities, it must cost different amounts of money. So you have to risk adjust the bundle, don't you?
Right.
So, and that's, anyway, we'll duke this out.
Tricky stuff. So
I can
may not be
actually
3 to 4
regrade
years,
him.
but it's on its way. Okay, who else? Gentleman back there. Just say who you are and who you're directing your question to. Well, pick one.
Well, Uwe, so how do you pay for the follow-up care? Because everyone knows that a good result is only as good as the follow-up. The longer everything's a function of the x-axis, the longer you follow up, outcomes deteriorate.
No, the bundle, at least the way we are talking about it, should have follow-up care in it. So it should be large enough to pay for the follow-up care, because you have at some point to draw a line and say from then on it's a new episode. And that's a complication, but I'm sure somebody like Bill could figure out what that would require or can in terms of follow-up, how much that would cost. That's probably not even the most, we can deal with that, I think.
All right, next question. This lady right here. Say your name and who you're.
Yeah, sure. My name is Ann O'Brien, and my question is, if you take the United States out of the equation for a second, and you look at all the other countries of the world, which country do you think has the best, although it may have its own flaws, but the best healthcare system when you look at access, total cost, both public and private, and then outcomes, quality?
I think if we don't let Uwe answer this, he'll be very upset.
Yeah. No, I will say, I would say Singapore right now and then Germany. I think those are the two best models for us to look at.
I might have thrown in Switzerland. It's a little more pricey than Germany, but high quality, very good quality. Cheaper than we are, but 30% cheaper. That would be a lot of money.
I think the point is, and I'm going to just throw in, because I think it's a great question, but it goes to the panels yesterday. Our delivery systems now, which are very doctor-centric, we're getting away from it, and academic places are getting away from it, the way they're training doctors, more team-based approach to have people at appropriate training and certification doing services instead of heart, lung transplant surgeon, down there doing things that other people could do. I'm just going to throw out there that we have a lot to learn from the developing world. We have a lot to learn from Rwanda, where I was, where vaccination rate is 94% up to the age of 18, where we're about 30%. Vaccination rate, which is all the things we've talked about today in terms of cost saving, burden of disease, prevention. It is by far number one, and it is cheap. The United States fails. And I just throw it out because people ask me all the time why I go to Bangladesh and why I go to Haiti, and these community health centers where you have community health workers, they don't even have to be trained and certified, but they can do a whole lot that we in America, because of our scope of practice, because of our protectionism as physicians, because of our state licensing, prevent. We're going to have to blow that wide open in order to get rid of this inefficiency, ineffective use of resources today, because our scarce resources are going to demand it.
We have to be careful when we make these comparisons, because part of the difference in our system is a country like Switzerland and Germany have a lot more that they spend in their welfare state than we do. As much as we complain about it, the social safety net is a lot more supportive there than it is in the United States. Additionally, the kind of drug problems, alcohol problems, vehicular accident problems, guns problems that we have, violence in this country, changes our mortality. Socioeconomic, sociodemographics, safety net, lacunae, and all those issues make the United States different.
Right here in the middle.
Thank you. Thank you very much for a very stimulating panel. The question is, we've been talking about...
Who is this for? Who is this for? Can you direct it to somebody?
The smartest one.
I'll take it. Go ahead.
Well, we haven't talked about regulations that... We talk about all this great innovation, technological innovation, but we have some serious problems with HIPAA regulations about very sequestered healthcare information. How do you see breaking through those barriers that will allow this casual interaction where you're collecting a lot of data, making decisions about that data? I haven't heard that discussed.
Yeah,
in the,
just real quick on where we are today. It's really good question because it goes to the big data question. In fact, we have more data than ever, and we will over the next 6 months compared to the last 20 years. It's unbelievable. And it's useful data, and we need to put apps on it to be able to interpret them. So HIPAA, I was part of the legislation itself. It was in the late 1990s. It was legislation, it was late 1990s, I say 1996 to 1998 when HIPAA was put in. It's basically privacy protection. It was a recognition at the time that your medical record was floating around in a hard copy and that anybody had access to it, anybody asked for it could go in the hospital and pull it off the record, and that is wrong. The challenge with HIPAA right now is that it was before the digital age. Right now, we've only had iPads now. iPads weren't only invented 3.5 years ago, the iPad itself. And so it was before the digital age, long before it, and therefore it needs to be updated. I will say, and I'm not as current as many of you in the room, the recent update in the last 6 months of HIPAA regulation has fixed a whole lot of that. And we might hear from somebody, but the experts who tell me when I question it. The other thing is this whole regulatory burden that is placed on individual physicians, and it kind of is where we started in terms of administrative expenses, is a big deal. And the simplification, I would argue that the government of role is one of establishing an ethical framework, coming back to make sure that we have the appropriate distribution going on, that we have the safety and sort of efficacy of drugs to the FDA. Once the track is set, the government is going to have to get out of the way, sort of monitor oversight. But the day where you can write HIPAA is a day that's gone by because things are moving so fast. And so we have to be very careful, but regulatory reform is a big part of what we do. I think for HIPAA, it's less of a problem today than it was 6 months ago.
Kim, did you want to say?
It's a problem. I mean, as we begin to think about information exchanges so that any hospital can reach any other hospital about somebody's medical record, it becomes problematic. I mean, if one of you in this room gets really sick and your healthcare medical record is mostly in, say, New York or Los Angeles, and you wind up in a hospital in Denver, it's not going to be a push of a button that's going to get all that stuff to the Denver hospital. It's not happening. They're going to have to call up. They're going to have to find out what the information is. It could take time. It could be wrong. There will be excess tests done that are unnecessary. We really need to figure out how to exchange this information in a way that still preserves confidentiality and the protections that people want around their privacy.
But Ken, how large is your compliance department?
Too big.
Yeah, because I served on the Duke board, and we had close to 15 going on 20 full-time people just making sure we were in compliance with federal regulation. You go to other countries, and I always ask the CEOs, how big is your compliance department? I say, compliance? What is that? They don't actually have this. So one question that I don't know how to answer is why do we need so much regulation like compliance, which sort of criminalizes?
You're sounding like a Republican.
Well, yeah.
He used to be very
What's
different.
going on? What's going on?
He used to be very different.
Well, he converted me. He put a new heart in me. Now
Is it harder? Is it a harder heart?
Republican
It's a
heart.
harder heart. All right.
Yeah, he
So
made sure
right
it
here,
was-
this gentleman right here is right front.
I have a question for the converted professor. And this is about the.
He's not really converted.
You didn't really do that
No, not
translation.
yet. Keep going.
I have a question about the influence of the informed consumer. Did I hear correctly that only 10 to 15% of of the technologically connected people need to be technologically connected to influence a market?
Yes.
Because that sounded like a rounded number. Can you elucidate a bit on that? Like what?
Yeah, I should have made it 11. But no, the argument is as long as there are enough buyers to hurt a provider, they will cotton to them. And take cameras, for example. My colleague Mark Pauly always points that out. When I go buy a camera, I don't have a clue. I don't even know how they work. But there are people that make that market really work. And I think in healthcare, it'll probably be that way too. And as you pointed out, with the Medicare Modernization Act, it did work out that way. Drug prices did get controlled, and most elderly are not computer savvy or do all the stuff theory says they should do. So long as you have a vigilant minority,
A vigilante minority? What?
Vigilante, yeah. That's
So if I'd like to sort of wrap, we're sort of close to the end of our time. I'd just like to wrap up with one last question for each of you. And if you could keep your response about a minute, that would be great. So when I was a young medical student back in 1981, I did my senior thesis for a public health course there on the unsustainable growth in healthcare. Now here we are 30 years later, and we're talking about the same topic, and the things, it sounds very, very familiar. If we were to come back on the stage 10 years from now, would we be having a different conversation? And if so, what would have changed the single most important thing would have changed between now and 10 years from now to make that conversation different?
I'll start.
You start.
I think in 10 years, what we're going to be thinking about is how come my care was denied? Because as we move to population management and we begin to connect providers with payers, there is now a new relationship. The provider and the payer want to diminish the amount of care that people get. Now, we know that there's a lot of excess testing, a lot of excess care, and it's going to be ultimately a good thing. But as we move to population management, the criticisms are going to be not that $9,000 hip should have been $7,000. It's going to be, I should have had a bypass, and they kept giving me statins.
Bill.
10 years from now, we started the Affordable Care Act 3 years ago now with about 52 million people uninsured. The problem with that, the people who are uninsured on day one, 6 months later, aren't the same people. As a product of that, the best estimates by the administration today are that 10 years from now, we're going to still have, we started with 42 to 55, we're going to still have, if everything goes perfectly, we're going to still have 32 million people uninsured. So the access issue, even though it's going to kind of be off the table at the federal level now, because we've dealt with it, nobody wants to touch reform at the federal level. At the state level, with increased flexibility of Medicaid, and hopefully we're going to move in that direction, we'll be able to address, since we don't have the answer at the federal level, the state level and the local level and the community level are where most healthcare solutions are going to be. 10 years from now, we'd have 32 million people uninsured. The GDP will be about 18%. I have no idea really, but progressive growth, where it was when you and I were in medical school, it was around 6%, and now it's 18%, I think will flatten over time. And I think the driving force issue that changes it is this nexus of information technology, big data, the informatics that big data allows, coupled with the drive to consumerism of 200 million people, or maybe the 10% of them, 200 million people making decisions instead of 535 people in Congress.
Uwe's making faces. He looks like
Well, he looks like
the coach from the German soccer team right now.
This guy doesn't learn. 18.3%. No, I remember, this brings me back. In my very first public speech was in Washington, I think 1976. And you know my wife, I wrote it up, laid it out, showed it to her. She looked at it and said, it's complete nonsense. And I said, it was very helpful. What's wrong with it? And I had all this, what we must do to control costs, because we economists were convinced if it reaches 10%, America ceases to exist. So she says, have you ever been at a truck spending conference? Or for that matter, how much we spend on alcohol? And in those days, we were spending more on alcohol and tobacco, I think, than on hospital care, and so on. She totally trashed my talk. So I gave, I didn't go there with any talk the night before. I had a couple of scotches, and just listened and then ran down everything I heard. And it was actually a very successful talk. I think we're now at 17%. One reason we tolerate it is the healthcare sector is the greatest creator of jobs. The bulk of jobs in America were healthcare. Yesterday, Pete Orszag said GDP is down, and the reason it's down because healthcare spending in the first quarter was down. Healthcare drives our economy in a major way. So in some regards, on the one hand, we curse health spending, but at the local level, try to close a hospital, it's your employment. But I think the debate, what is it, 10 years you said from now?
10 and a half.
I think we will have shifted from just raw, we must cut health spending, to what are we getting, the theme of this session. And I believe, given what we discussed, that we don't have to know what a life year is worth in dollars in America. But we do know that if we eliminate some of the waste we were talking about, we will get more value for the dollar. It's all you need to know at this stage, because we know of all the waste, the IOM study, and so on. And I think we will be debating more of the value question and less just this, we can't afford X%. Imagine we spent 30% of GDP on healthcare. We got rid of Alzheimer's, of cancers, and had a Viagra pill that lasts 50 years. Now, you might take that bargain, right, for 30%.
Yeah.
I would.
That's a good deal. No,
So-
that's a good deal. That's a good. Well, I want to thank our panelists, but before I wrap up, I'd like to let everybody know that Uwe is going to be playing Vegas, July 4th weekend, and you can catch him there. So if you're be sure to catch his act. So once again, thank you very much. Great conversation. Let's have an applause for our panel. Thank you.